Hello, everyone, and welcome to today's webinar, HPV Testing Through Different Lenses, Strengthening Lab and Physician Partnerships to Improve Patient Care. I am Kaylee Bach of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by BD. To learn more, please visit bd.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. And with that, I'd now like to welcome our speakers, Dr. Jenny Meredith, Clinical Microbiology Director, Prisma Health System, and Sara Ezra, Molecular Supervisor, Pathology Consultants. For a complete biography on our speakers, please click on the Presenter tab. Jenny, Sara, thank you for joining us. You may now begin your presentation.
Thank you for that introduction, and thank you again for the time to talk about HPV testing at Prisma Health and Pathology Consultants. So Prisma Health and Pathology Consultants are located in beautiful Greenville, South Carolina. Greenville's about 2 hours from Atlanta and 2 hours from Charlotte, North Carolina, in the foothills of the Blue Ridge Mountains. Prisma Health is a large system with 18 acute and specialty hospitals, over 2,800 licensed beds, and over 300 affiliated physician practices that extend across the upper and middle part of the state of South Carolina. Pathology Consultants provides all of our pathology services for all Prisma Health facilities and practices, as well as to physicians' offices across the upstate that are not part of the Prisma Health system. Today, Sara and I are going to talk about HPV testing, how it plays in cervical cancer screening and screening guidelines, as well as our experience with extended genotyping and automated assays for genotyping, and the benefits that we believe this assay has for our patients and leads to better patient care. So let's start by reviewing what we know about HPV and its role in cervical cancer. Human papillomavirus, or HPV, causes more than 90% of all cases of cervical cancer and is a common sexually transmitted infection. HPV infections can be caused by many different genotypes of the virus. Low-risk types are associated with genital warts, while high-risk types, that are the numbers shown here, are associated with cervical cancer. While these are all high risk, they do differ in their risk for developing precancer and cancer, which are diagnosed in 200,000 and 11,000 women, respectively, each year. Cervical cancer and precancer are really just the tip of the iceberg, and they're most commonly associated with HPV. However, there are other cancers that are also attributed to HPV infection and are preventable by vaccination. Although HPV is the first cancer preventable by vaccination, less than half of eligible patients are getting vaccinated. And additionally, even vaccination doesn't cover all of the HPV genotypes that were shown on the previous screen. For these reasons, it is particularly important to have a good screening tool to catch the disease early. Cervical cancer is the only type of cancer that can be detected at an early stage with effective screening with HPV testing, and all HPV tests on the market are FDA cleared only for cervical cancer and precancer detection. So what are those screening guidelines, and how does HPV fit in? I think first it's important to know kind of the terminology that we'll be using throughout this talk. There are two main systems used to classify cytological changes in the cervix. During this talk, you will primarily hear me refer to the CIN system. The cervical intraepithelial neoplasia system is used to classify precancerous lesions, with CIN 1, 2, and 3 referring to grades of precancer, with CIN 2 and 3 being at highest risk for development of cancer. The other commonly used system that you may have heard in the past is the Bethesda system, where LSIL, which stands for low-grade squamous intraepithelial lesion, corresponds to the lowest level of the CIN system, CIN 1, and HSIL corresponds to the higher levels, CIN 2 and CIN 3. HPV tests provide better negative predictive value for CIN 3 positive compared to just cytology alone. So screening for cervical cancer by examination of the cervix to detect these neoplastic lesions began in the 30s with application of iodine directly to the cervix for visualization. Physicians started using the pap smear around 8 years later in 1941, and it wasn't until 85 that scientists discovered that HPV infection was linked to cervical cancer. 14 years later, the first test for high-risk HPV testing hit the market, and you can see the flurry of activity since that time, with HPV testing continuing to evolve and continuing to improve detection of precancer and risk to development of invasive cancer. Currently, the American Cancer Society recommends cervical cancer screening to start at age 25, primarily with HPV screening every 5 years until the age of 65. While the USPSTF recommendations currently differ, particularly in that they recommend cytology alone from age 21 to 29, these recommendations are under revision and are expected to be updated to align with the ACS in the near future. When HPV testing is used as the primary screening method, shown at the top of this slide, results drive next steps in evaluation and treatment, with a positive leading to cytology or possibly directly to colposcopy, depending on the genotype. Co-testing uses HPV and Pap testing results that are performed in parallel and are reported together. And reflex testing starts with cytology, driving HPV testing if abnormal. All of these approaches are acceptable screening methodologies currently. Now let's talk about the importance of genotyping, particularly extended genotyping that is provided by the BD OnClarity assay. Most FDA-approved HPV tests provide partial genotyping. Early studies identified HPV types 16 and 18 as those at high risk of leading to cervical cancer, and later HPV 45 was also found to be high risk and is sometimes called out in testing along with HPV 18. These tests also pool detection of the other 12 high-risk genotypes into a single result. Some of these, you will see, actually have higher risk of precancer than HPV 18. The difference in the OnClarity real-time PCR assay is that it individually reports 6 of the 14 high-risk genotypes, with other genotypes strategically pooled and reported based on their risk profile. The OnClarity assay has several advantages in addition to its ability to identify additional genotypes. There is less cross-reactivity with low-risk types, meaning lower risk of false positives, and the internal control and the chosen target region of the HPV genome minimizes the risk of false negatives. Additionally, the test has high sensitivity for both active and latent HPV infections. So now that we know all of these genotypes and we have all of these genotype results, what do they mean for risk and for the patient, and why do they matter in management of cervical precancer and cancer? So in a 2019 study, Stoller and colleagues looked at the risk associated with additional genotypings. You can see in the red box that those genotypes at highest risk of a patient developing SIN3+ were HPV 16 and 18, with intermediate risk for HPV 18, 33, 58, 52, and 45. Note that in patients 30 years and older, HPV 31 had the highest risk of greater than or equal to SIN3+, greater than that of HPV 16. So this study demonstrated that while we have been concentrating on HPV 16 and 18, other genotypes showed similar or higher risk for cervical precancer, particularly HPV 31. HPV genotyping is an important part of risk stratification and drives next steps in diagnosis and treatment. A study that followed close to 5,000 women with normal cytology at baseline over 3 years was able to tease out those associations between HPV genotype and risk. You can see that a negative HPV result was as effective as co-testing with cytology in assuring no disease at 3 years. You can also see that HPV 31 actually posed the highest risk for progression from normal cytology to cervical precancer or cancer within 3 years and exceeded the ASCCP threshold for risk and referral to colposcopy of 4%. So the use of extended genotyping can not only optimize disease detection, it can better stratify risk and prevent excessive colposcopy procedures. We do know that most women will clear HPV infection, and many can be infected with different genotypes over time, but it is the persistence of high-risk HPV over time that is the predominant risk factor for progression to cervical cancer. In this study of Swedish women who were HPV positive with annual follow-up, all women in the study with a persistent infection developed SIN2 plus or worse within 6 years. In those who cleared the virus or switched genotypes, there was no development of SIN2 or greater disease. So the reporting of pooled high risk can actually mask persistent infection or a switch in genotype. Giving the physician data on a specific genotype can then help guide how they follow up with patients who test positive over time with an other high-risk genotype. Risk-based management is the current recommendation of the ASCCP. This means that the recommendations for colposcopy, surveillance, or in some cases expedited treatment are based on immediate risk of SIN3+. HPV typing allows for this stratification, with any type identified that shows immediate risk greater than or equal to 4%, leading to some type of action, colposcopy and/or expedited treatment. Extended genotyping can be used to further stratify the risk of SIN3+. We've seen data in the previous slides showing how specific genotype beyond 16 and 18 align with the risk of SIN3+, and this data would clearly impact the patient in this risk-based algorithm. Now let's look at how the specific HPV genotype reported fits into the current screening algorithms. This slide shows the current algorithms that exist for cervical cancer screening, the one on the left based on primary HPV screening, and the one on the right based on cytology alone with reflex to HPV testing. You can see that in both algorithms, HPV 16 and 18, which are highlighted in red, are the only genotypes called out for reflex to colposcopy. Also in both algorithms, a positive high-risk HPV result that is not 16 or 18, or where the genotype is not known, can lead to surveillance or follow-up in 12 months, and that occurs when cytology is normal. Additionally, the algorithm on the right does not even reflex to HPV testing when cytology is normal, which could miss the underlying infection that could eventually lead to precancer and cancer. Now we know that HPV poses a high risk for progression from normal cytology to cervical precancer or cancer, and we know that there is a risk higher than that for HPV 18 with some of the types shown here, particularly HPV 31. So I think it's safe to say that the data is there to support incorporation of the risks of these additional genotypes into the recommendation. This algorithm could misclassify someone with HPV 31. They would not meet the 4% threshold for cytology or treatment, and the patient may wait 12 additional months for retesting. The decision of pathology consultants was to provide as much information as possible to our physicians so they could better understand the risk of their patients. Sara is going to discuss the assay and that we now perform and how it has been incorporated in the pathology consultants lab.
Thank you, Jenny. Now I will talk about the core system, including workflow at our lab. Prior to 2014, pathology consultants sent our HPV testing to a local reference lab, but it would take 5 to 7 days to get results. The reported results were 16, 18, and the other high-risk group. In 2014, we brought HPV testing in-house to provide a better turnaround time. We were reporting the same 3 results. In 2018, with BD on Clarity, we were able to call out genotype 45 as a separate result, reporting 16, 18, 45, and the other in a high-risk group result. Then in 2022, we were able to report out 6 individual genotypes, 16, 18, 31, 45, 51, and 52, and 3 groups that are 33, 58, 36, 39, 68, and 56, 59, 66. After testing over 29,000 samples in 22 2022, we were looking to improve our workflow with more automation. We found the solution with BD Core. 3 key points to the system for us were it was fully automated from specimen to result. It was a multiplex PCR assay design with less than 1 hour hands-on time and under 24-hour turnaround time from loading to result. When implementing BD Core, we focused on 5 areas: workflow, training, maintenance, validation, and launch. For workflow, performing the HPV testing before the pap smear worked best for us. Training. Training was a process of introduction and becoming familiar with the instrument. Maintenance. Maintenance includes daily, weekly, and monthly. Daily taking about 5 to 10 minutes, weekly, which also includes daily, about 15 minutes, and monthly, which also can include weekly and daily, would take no more than 30 minutes. For validation, we tried to mimic the original PAP vial, and for launch, BD was right by our side until we felt comfortable. This is a typical day at our facility. The day starts with maintenance, daily, weekly, and/or monthly, and then we start loading PAPs. At that point, we can walk away. The aliquots are made on the analyzer. It pre-warms on the analyzer. It can run multiple runs at a time. Since we're loading bulk reagents, there's less changing, adding reagents. There's less QC to perform because we're only performing on new lot and or shipment. There's less cleaning, washing of the instrument, the racks. The BD Core calculates the rate of positivity. We don't have to stand in front of the machine. We can work at our desks doing other tasks while continuously monitoring the system. And less hands-on time equals less possibility of cross-contamination, which we all want. Since there is no end-of-day cleaning, you can continually load and run on the core overnight if needed. This is a comparison of workflows between BD Core and our previous instrumentations. With the capability of running overnight without any tech intervention, we are able to report out more results. Instead of spending hours aliquoting samples, it's able to free up our time, the teams, to concentrate on other projects. We're able to compile data looking for trends. We're able to educate our clients on collection, labeling, good lab practices, and we're also able to grow the business because we offer a single test with 9 results. For the system training of the BD Core, keep in mind training is a process and it's unlike any other platform. During training, you'll learn how the system works and understand the maintenance involved. After go live, learning the system continues as you run samples and troubleshoot with the support of BD. The more you run, the more comfortable you'll become with the system. And you have to trust the process. Learning continues after training. It is not one and done training. Initial training took about a week with our focus on becoming familiar with the core. For maintenance, I briefly spoke about daily, weekly, and monthly. The maximum you're going to spend on monthly, daily, and weekly altogether is 30 minutes. That includes loading reagents for your day. There's minimal downtime due to BD's ability to log in remotely. They sometimes know the issue before we do. We can walk in and they've already logged in and encountered what was going on. Also, if there's errors on the machine, there is a timestamp So if we do have to call it in to BD, we can tell them exactly when it happened, and they can go back and look at the multiple cameras located within the core to see exactly what happened. BD is continually trying to improve BD core. We are able to provide feedback on what works, what doesn't work, and any ways we think that it could be improved. For our verification, we used a combination of patient SurePath samples and controls previously run on the LT using OnClarity. We added the residual cytology tube to the residual SurePath vial and transferred it to a new vial with either no additional, medium, or very minimal. And this was our process for verification to avoid further dilution of the sample and also to account for high CT values. Since ThinPrep is also FDA approved on the core, we will plan a similar verification to be able to offer extended genotyping on either type of PAP vial. So now we'll look at prevalence data here at Pathology Consultants and case studies. This shows a breakdown of the genotype results we have had at Pathology Consultants since 2014. Keep in mind, we're testing for the exact same 14 genotypes throughout the years, but you can see a clear breakdown of these gray blocks that encompass all the genotypes and what that really means and which genotype is more prevalent than another. It also illustrates the combined prevalence of 16 and 18 does seem to be trending down for our data set over the years. As you can see with reporting 9 results, how much more information the clinician is seeing now compared to before. Thank you.
Okay, thank you, Sarah. Now we're going to look at a couple of cases to understand how the physician can use extended genotyping results to manage patient care. The first case is a 35-year-old patient with a history of abnormal pap smears for as long as she can remember, and she denies history of excision of the cervix. In September of 2019, she tests positive for the pooled high-risk HPV genotypes, but negative for 16 and 18, which you've seen on previous slides, are called out in the testing algorithm as high risk. Because her pap cytology is negative, the algorithm prompts the physician to follow up with this patient in 12 months. 12 months later, she again has a negative pap, but is high-risk HPV pool positive. And then 2 additional months later, she undergoes colposcopy and curettage and is negative for precancer. 2 years later, following her surveillance, she undergoes screening. And not only is her pap atypical, she is positive for HPV 31 with an extended genotype assay. Now, we know her risk for SIN3 is high based on HPV 31. She does undergo a colposcopy, which is determined to be SIN3. 2 months later, she undergoes treatment via cold knife cone biopsy with clear margins. Had the physician known the patient was HPV 31 positive at that first HPV screen in 2019, the timeline would have been much different, with colposcopy and/or expedited treatment initiated 2 to 3 years earlier for this patient. Also, if they had been doing extended genotyping all along, then it may have shown persistence of the high-risk genotype HPV 31. But we are unclear in this case whether she had persistence of the same genotype or if there was a genotype switch. In case number 2, a younger 29-year-old patient who reports a long history of abnormal cervical cancer screening results. She denies any other previous colposcopy, and she's referred for an excision after a recent colposcopy showed SIN2 at an outside practice. In March of 2022, that abnormal cytology is paired with an untyped HPV positive result, and then the following month is that colposcopy that's SIN2. She then returned, and her pap was negative, but she was positive for both HPV 16 and 31 by extended genotyping. The physician then took her directly to excisional treatment, which showed SYN3. Either of these genotypes alone would place this patient in a very high-risk group, with the recommended next step being either immediate excisional treatment without biopsy confirmation or a colposcopy that targets multiple areas of the cervix. Again, knowledge of the genotypes present for this patient should have prompted an earlier decision to treat. In conclusion, we know that genotypes other than 16, 18, and 45 carry high risk of SYN3+, particularly HPV 31. Additional information through extended genotyping improves SYN3+ risk discrimination and facilitates genotype-specific persistence tracking. This is important because current recommendations are risk-based, and I think it's clear inclusion of HPV 31 along with 16 and 18 should improve effectiveness of the screening algorithm in determining patient risk for SYN3+. In implementing this testing, Sara spoke nicely to how the core system has automated the testing process to decrease hands-on time and improve workflow efficiency, allowing pathology consultants to produce more actionable results each day. And again, at the end of the day, it is encouraging to remember that cervical cancer is preventable thanks to the screening tools, treatment tools, and an effective vaccine. Thank you, and I'm happy to take any questions. Or we're happy to take any questions.
Wonderful. All right. Well, thank you so much, Jenny and Sara, for your informative presentation. We will now start the live Q&A portion of the webinar. So to our audience, if you have a question that you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. All right, so let's get started. We've already got some great questions coming in here. So we'll go ahead and start with this one. This first question asks, when do you anticipate the ASCCP will add XGT to the enduring guidelines?
So it was announced in May of this year at their annual meeting that extended genotyping should be added to the guidelines by the end of this year or early next year. So currently that draft is being finalized, and hopefully we'll see some changes then.
Wonderful, thank you. All right, next question here asks, what has been the biggest impact to your organizations by using BD on Clarity and BD Core?
The biggest impact for us has to do with workflow, the hands-on time, and the ability to have patient results either the same day that we receive the PAP or the next day. Being able to run overnight on the BD Core and walk into the lab at 6 or 7 a.m. and have over 120 possibly results to release is a huge impact for our organization and for the patient.
And then from just a patient perspective, obviously we feel like if physicians are aware of the algorithms and how extended genotypes can also affect risk, that should be impacting patient care just from adding extended genotyping to our test menu.
Great, thank you. All right, moving forward to the next question here. This is a two-part question. Did you do any training for your clinical teams on how to manage results for HPV types beyond 16 or 18? And if so, what did that training look like and who led that?
So it was a multi-pronged approach to this because we have so many providers with varying knowledge of the different genotypes and their risks because they've not seen them reported before. So they've never really had to interpret that result. So Pathology Consultants, in coordination with BD, did some education for our providers. They do at PC employ MedTech who kind of acts as a liaison and goes out and does training as needed, and BD helped with that training. So that was one way. The other is the medical director of Pathology Consultants went on kind of a speaking circuit locally and regionally to talk about this new extended genotyping that we brought in and what the risks mean. So that was kind of the approach that we took with our providers.
Great, thank you. All right, next question. You mentioned the vaccine impact on the prevalence of HPV types. The prevalence data from Pathology Consultants showed a decreased prevalence of HPV 16 and 18 over the years in their data set. Do you know of any other studies that show a similar pattern?
So there are several studies that have shown similar patterns. So a study in The Lancet by Drolet and colleagues found that in looking at over 60 million individuals, they found that 5 to 8 years after vaccination, they did see a decrease in prevalence. They also saw a decrease in anogenital wart diagnosis and SIN2 positive. So that was a big win. Also, the Costa Rica vaccine trial looked at the genotypes post-vaccination, and they found that in the vaccinated population, there was a decrease in 16, 18, 31, 33, and 45 as expected. And those vaccinated seem to have other HPV genotypes. And then Rosenblum and colleagues was another study, and they found a significant decrease in vaccine strains for women and girls ages 14 to 34. So I don't think it should be any real surprise that as we vaccinate more of the population, we see some of those genotypes decreasing in prevalence. If you look at the Pathology Consultants data, we did see an increase in 45 and 31 over that same time. And, now we're looking at 31 and we can see how it plays into this change in genotypes over time. So, but yes, others have seen a similar thing with 16 and 18.
Great, thank you. All right. Like I said, we've got some great questions still coming in here, and we do have time, so we're going to continue. This next question asks, what has been your clinical team's feedback on extended genotyping?
So the feedback has been positive. I think that this isn't something that's offered in very many places, and they feel pretty lucky to be at the forefront of some of this data and being able to detect those genotypes for their patients. So good positive feedback from our providers.
Great. Now, what made you decide you needed to go towards more full automation in the laboratory?
We decided after testing almost 30,000 samples last year, and the amount of hands-on time, the amount of time spent touching every single sample, because we were taking a sample under the hood, checking a name against the label on the aliquot tube, vortexing it, aliquoting, and you want to times that by 30,000. That's how many times we're touching that PET vial. And we wanted something more automated, more hands-off. With molecular, you're always looking at the possibility of cross-contamination, and looking at all those factors led us to the BD core.
Great, thank you. All right, next question here. What was the #1 aha moment when you brought in the BD on Clarity test?
I would say after training, after go live, when we could load the machine while we were here and let it run overnight and walk into all those results, and the ability to verify them within an hour and get them out the door. Less than 24-hour turnaround time. I think that was the huge impact for us.
Great, thank you. All right, next question here. What other tests do you have on the BD core system that are automated?
We also run chlamydia, gonorrhea, trichomonas on the BD core. We can run a urine sample on a male or a female, or a female vaginal swab. And that's also very hands-off. We load the sample, and we have results within about 2.5 hours.
Wonderful. All right. Well, it looks like we have time for one more question today, so we'll go ahead and wrap up after this one. And this final question asks, have you started thinking about going to primary HPV testing?
So because Pathology Consultants basically acts as a reference laboratory for many OBGYN offices across the state, it can certainly be a recommendation, and I think we can certainly provide the data and the guidance to those that we serve to push them in that direction, especially if we have additional guidelines come out to support that. So not that we can implement that, but it's certainly something that we can promote for our practices.
Well, that will conclude our session for today. Jenny, Sarah, do you have any final comments for our audience?
I just want to say thanks for allowing us to talk about this. I know that there are not a lot of places that offer such extended genotyping, and we really feel that it's impacting our patients, and very happy to be part of this, bringing BD assay online here in South Carolina.
Thank you for letting us share about our experience with BD Core, and thank you, BD.
Great. And thank you again, Jenny and Sarah, for your time today and your important research. We would also like to thank LabRoots and our sponsor, BD, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by our speakers via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. So until next time, take care, everyone. Goodbye.